FMC News. I'm your host, Chris King. Today we have a special addition to our nursing segment this morning. Here we have some third-year nursing students from Mount Royal University, and they practice here on Unit 21 and 22 at the Foothills Medical Center. And today they're here to talk about suicide in the adult population. Welcome Devi, Kaylee, and Lexi.
Thanks for having us.
So we hear that there are some clinical guidelines that you guys are hoping to introduce to your unit. Can you expand on that?
Yeah, we find these clinical guidelines are important for practice because it allows nurses to be non-judgmental regarding suicidality, and it allows individuals who are experiencing suicidal thoughts to be heard.
It also decreases feelings of guilt and shame in the individual because as nurses, we can provide them with the resources they need to overcome their illness and bring them on a journey to better health.
These guidelines are also important because it allows the nurse to become aware of the patient's baseline and to collaborate with patients to come up with a mutual goal that promotes hope with the patient during hard times.
Wow, that's extremely eye-opening. What have you seen in your practice that made you want to introduce these guidelines?
We have only been practicing for 4 weeks, but we have already seen gaps regarding patients' comfort in disclosing their feelings due to cultural stigmatization toward mental illness. I have seen this have a profound effect on my patients' well-being, which in turn affects their length of hospitalization. For example, I had a patient that believed having schizophrenia meant he was going to be punished by a higher power and thus felt he was less of a person for having the diagnosis. This caused him to become socially isolated and did not want to disclose with his family or friends due to his fear of shame and guilt.
It is important to recognize how cultural diversity can impact a person's behavior and interactions when they are talking about their mental illness and the stigma around their illness, as it may have an impact on their health outcome. It is also important to be aware of patients' cultural norms and beliefs when preparing a care plan for a patient, as it may affect how they respond to the proposed interventions. A patient's culture can also affect their insight and judgment in regards to their mental illness.
I can see that this can take a lot of patience and cultural awareness to implement. Do you feel like the guidelines are appropriately addressing the stigma around culture and mental illness?
The guideline addresses both stigma and cultural competence separately, but we believe that there should be more of an emphasis on understanding our patients' cultural values and beliefs regarding mental illness. As human beings, we tend to believe and unconsciously assume that everyone thinks about mental illness in the same regard, but in reality, we know this isn't the case. We find that every culture brings its own interpretation of mental illness, whether positive or negative.
That is very true. You never really think about it until it's actually brought forward.
Yeah, interesting, isn't it? We want to bring forward recommendations to our nursing practice at Foothills Medical Center. The first being, the nurse works with the client to minimize the feeling of shame, guilt, and stigma that may be associated with suicidality, mental illness, and addiction. And secondly, the nurse provides care in keeping with the principles of cultural safety and cultural competency.
We find that these two recommendations can be interrelated, as we have stated before, due to the fact that some cultural beliefs affect the perception of mental illness. Therefore, as nurses, we must be aware of these cultural differences and stigmatizations and practice accordingly to best fit the patient's well-being.
So we have some video clips to show you that display an interaction between a nurse and a patient whose views about mental illness are altered due to cultural beliefs.
Oh, that's fantastic. Let's roll the clip.
Ron Burgundy, a 25-year-old male diagnosed with major depressive disorder, was brought in with suicidal ideations and feelings of hopelessness.
Alright guys, I'm just about to go have a one-to-one conversation with Ron Burgundy right now. We're going to discuss his culture at this time. Hey Ron.
Hey.
I'm Kaylee, I'm your student nurse today.
Hey.
Hey. So today I think I just wanted to know how you're doing.
Not so good. Ever since I left where I lived, I feel so empty inside, and the way I was treated, it just bugs me so much.
What do you think is causing that emptiness?
I think I felt like I was ousted as an individual in my community because my diagnosis. I disclosed my diagnosis to people I trusted, and They turned their back on me.
Wow. Ron, you said that they ousted you. What do you mean by that?
It's just that as soon as I told them I have depression, they just turned their back on me. You know, they felt like I was a different person, and that I was no longer with that group anymore. They just completely disregarded me, and that's where that emptiness feeling comes from. I feel like I connected so well with them, and now in the blink of an eye, it's all gone.
When you explain this as an emptiness to you, what are you feeling? What does that mean to you?
I just feel that I myself am empty. I'm not the person I used to be. I'm not who I once was. I've been shunned by my family and my friends, and that would meant everything to me, being a part of that, and now I just feel empty. There's nothing left to live for at this point.
Look, Ron, I appreciate you sharing this with me today. It takes a lot of courage to come in here and to face your battle. I just want you to know that we're here to help, and no one here will judge you at all. We'll only support you and listen to what you have to tell us and listen to your stories. I'm really sorry that this is happening to you.
I appreciate that. Thank you so much.
You're welcome.
That was a great video. Definitely helps to understand what you guys do in the clinical setting. Do you see any barriers or facilitators in implementing these guidelines?
On our unit, a facilitator we see is nurses foster a non-judgmental approach when communicating with patients after disclosure occurs. The non-judgmental environment allows the patient to express their feelings regarding their mental health.
Another facilitator is that we've also seen the use of a language line for those on the unit who do not speak English, making it easier for nurses to understand the patient's needs and comfort level.
Barriers to achieving these guidelines are related to nursing attitudes towards culture. Some nurses may shy away from asking patients about their culture and beliefs. It could be an issue of the nurse being uncomfortable due to his or her own biases, or due to possibly feeling intrusive to the patient's boundaries.
A second barrier to achieving these guidelines are the heavy patient loads that many nurses find them placed under on Unit 21 and Unit 22. Caring for 5 or 6 patients at a time makes it difficult to engage in one-to-one interactions that make it difficult to assess all aspects of care. As a result, culture tends to fall further down the list of subjects to discuss, whereas social support networks and the diagnosis itself tend to be the focus of the conversation.
Finally, the last barrier we discovered was also found after review of documentation. One-to-one interactions were not performed for days at a time. This was shocking to us as nursing students, being taught to have interactions with our patients every day.
Thanks for that information on stigmatization and cultural nursing practice. Now let's move into your second recommendation for the clinical practice. So I hear that as nursing students, you are hoping to address a second clinical guideline that's related to adults and suicidality. What may that be?
That's correct, Chris. We are hoping to address an issue regarding the documentation of suicidal ideation. As we all may know, suicide and harmful ideations, along with the mental illness itself, are the major reasons for being hospitalized to a psychiatric unit.
Oh, definitely. I believe most nurses are aware of such. So which guideline do you think this would relate to?
The guideline we referenced is organizations implement policies regarding the systematic documentation of suicide risk assessments. We believe it should be adapted to fit our clinical practice, as organizations implement policies regarding the systematic documentation of suicide risk assessments on flow sheets with NPR notes attached when necessary on adult psychiatric units.
For example, we have found that there is a component missing to facilitate easy documentation of a suicide risk assessment. Typically, we would document a suicide risk assessment in an MSE, mental status examination, or a one-to-one NPR. But we have found this to be hard to track a patient's baseline.
With the guideline adapted as same, we believe nurses will then feel an obligation to ask their patients if they are having suicidal ideations every shift, and further ask the patient to rate their suicidality on a scale of 0 to 10, With the information received, the nurse will then document the information in a flow sheet that prompts the nurse to write an MPR if the patient stated their suicidality anything above 0/10.
With the information regarding a patient's suicidality documented on a flow sheet, it would allow a nurse to better understand a patient's baseline, whether they have worked with this specific patient or not.
Wow, you guys must have really worked hard on this. Now, what would you see as barriers or facilitators in achieving this clinical practice recommendation?
We think that a barrier in our clinical setting to achieve this clinical guideline would be that policy changes and software updates can take months to complete and must be approved by a number of professionals before changes can be made. Ultimately, this would delay the goal of having effective documentation techniques regarding suicidality in patients.
Facilitators to achieving this guideline would be that this would increase patient safety and foster confidence in nurses. When nurses work on a casual basis, they are more prone to receiving patient assignments of individuals they have never worked with before. This will allow them to be more confident in understanding their patient's current risk of suicidality and act appropriately on such as not allowing passes or unaccompanied privileges when patient reports 5/10 or higher.
Another facilitator is that this will allow nurses to communicate effectively with each other throughout the report. By being aware of a patient's baseline, they can quickly discover changes and further pass this information forward to the next shift, so the interdisciplinary team is aware of who on the unit is most at risk for suicide behaviors.
I think your interpretation of the guideline sounds absolutely brilliant, and with minimal barriers, it appears to be a facilitator of safety for the patient population. What's this? You guys have another video kit displaying the benefits of proper documentation and report? Way to steal the show, guys! Let the film roll!
So I'm just going to go in to see my patient Jessica Jones. She's currently suffering from major depressive disorder and anxiety, so we're just going to see how her day is going.
Hi Jessica, I'm Debbie. I'll be your student nurse for the day. How are you feeling today?
I'm just having a really hard day. My anxiety is out of the roof, and I just feel like I'm so low and depressed. I just don't know if I can take any more of this.
Are you having any thoughts of hurting or killing yourself at this time?
I don't think so. No, not.
On a scale of 0 to 10, 10 being wanting to hurt yourself and 0 being none at all, where would you rate yourself?
Oh gosh. If you put it that way, I guess I would say I'm a 6. 6 on that scale.
She realizes she missed an aspect of the suicidal assessment when she was interviewing her patient. So she decides to return to the patient to gather the additional data needed for a complete assessment.
So Jessica, earlier you told me you were at a 6 out of 10. I'd just like to know more about how you're feeling about this. Do you have any plan or means to carry out this suicide?
No, I don't have a plan or a means. I just don't feel safe in my mind right now. It is just a whirlwind of thoughts, and I can't seem to focus on living.
It must be very difficult. Thank you for sharing. We are here to help you, and we can get through this together.
Here the nurse enters the Cardex at the end of her shift. Patient rated her suicidality at a 6 out of 10, which is more than a 0. This Cardex she has currently written does not accurately convey her patient's current mental status. This can lead to miscommunications between healthcare providers, thus decreasing patient safety.
Code yellow, unit 7-1. Code yellow.
Luckily, the nurse catches herself before submitting and enters a much more appropriate report for the next shift. This updated Cardex will allow future healthcare providers to anticipate and implement appropriate nursing interventions.
Thanks for joining us on this special edition of FMC News. My name is Chris King, reporting off. Stay classy, FMC.